Hello guys, this is Dr. Asif. Today I'm going to make another video of physiology part B. Though you all know that I am teaching about the MRCS part A, basic physiology. It's very important nowadays because there are some questions which is asked in the exam, like very basics from fundamental things from the physiology, like 10 to 20 questions. and which is necessary, I think. I hope this video will help you to go through with the topics as I know, which is very important, and which is one of the most important part of paper 1 exam, that we know that maximum questions come from the anatomy, and the rest of the part and a basic part come from the physiology. So in the previous video I already asked you above up to the bleeding portion, or that is coagulopathy or coagulation related physiology. Now the next one is cardiac physiology. So cardiac physiology, the heart of 4 chamber, okay, both low pressure and the high pressure system. Okay, so there are 2 pressure system that is ejecting from both low pressure and high pressure. The pump generate pressures is about 0 to 20 millimeter of mercury on the right side, and the 0 to 120 millimeter of mercury to the left side. Okay, and the rest of diastole comprises 2/3 of the cardiac cycle. Okay. Now the cardiac properties: increase intrinsic myogenic rhythm within the cardiac myocytes, means even the denervated heart is capable of contractions. So, and the normal situation of cardiac impulse is generated in the sinoatrial nodes in the right atrium and conveyed to the ventricle by atrioventricular nodes. This is almost normal physiology, you know. And the sinoatrial node is also capable of spontaneous discharge. In the absence of background, vagal tone will typically discharge around 100 times more per minute. Hence the higher resting heart rate found in the cardiac transplant cases. Okay, and the SA node's resting membrane potential is lower than the surrounding cardiac cells, will depolarize from -70 to -50. What it means, because the resting membrane potential of normal heart is within -70 millivolt to 50 millivolt. Difference in the depolarization slopes between the SA and AV nodes help to explain why SA node will depolarize fast, because SA node will produce the more action potential, that is -90 or -70 to -90. It is almost more than the normal range. That's why SA node will produce the first impulse from the right atrial wall. Now the parasympathetic fibers project heart via the vagus, will release acetylcholine. You must remember this very much clearly. The sympathetic fibers release noradrenaline, and circulating adrenaline comes from the adrenal medulla. And the noradrenaline binds to beta 1 receptor in the SA node and increase the rate of pacemaker potential depolarization. Now here you can see there are some phases of cardiac cycle: isovolumetric contraction, ejection, relaxations, rapid flow, diastole, and arterial systole. So you must know the cardiac cycle, though it is not the part of part A, because it will be discussed on the part B in the physiological portions. That will be discussed in that time, because there are some phases of, and there are some changes of ECG or changes of arc point of different atrial and ventricular portion. Now there are some mid diastole. The AV valves open and ventricles hold 80% of final volumes, and the aortic pressure is high. And the late diastole, the atria contracts and the ventricles receive 20% of the complete filling, and the end diastolic volume is 130 to 160. Early systole AV valve shuts and ventricular pressure rises, isovolumetric contractions, occurs in the early systole. You must understand, because it is early systole. In the early systole, isovolumetric contraction happens. Okay, let me okay. The epivalve bulge into the C atria and the X descends. I already told you about the JVP. So there are some changes also occurs in the JVP. And so there are late systole. The average stroke volume is 60 volume. You must know that a normal person can make push from their left ventricle about this, what is stroke volume, the amount of blood that is ejected in per minute. This is a stroke volume, almost 70. It coincides with the body weight. Like say if a person has a 70 kg weight, in that case the stroke volume will be 70 ml. Sorry, that is the volume that ejected in each minute. So each beat. Okay, so early diastole, all valves are closed and the isovolumetric ventricular dilation occurs, and the closed the aortic valve increases aortic pressure. So during systole, the arterial pressure increases such as it is now above 0, and eventually arterial pressure exceeds the ventricular pressure and the valves open. Okay. Atria empty passively into the ventricles because it is a Y descent. I already told you that X descent and Y descent, that is ventricular atrioventricular valve is open. Now ventricle is started to increasing and atrial is contracted. In that case, that is Y descent occurs. The atria empty passively into the ventricles and atria falls, pressure falls. Okay, that is Y descent. And what is X descent? That is atria downs and drops intraarterial pressure. That is X descent, shortening of the ventricular pulse. X descent and the Y descent. These two things very important for GVP, that you all know about. In the first page of the previous lecture, I already show you that X descent and Y descent means the pressure difference from the atria to ventricles. Now the two things, preload at end diastolic volume and afterload aortic pressure. And you must know this very clearly, that a preload means end diastolic volume. That means when the atria or both atria is started to increasing the last limit of enlargement, when the pressure or the arterial pressure, that is wall related pressure volume, is when the last limit of enlargement of the atria, both atria, left and right, that is end diastolic volume. It is preload. And afterload means the end ventricular volume, that is left ventricle and the right ventricles, the last limit of enlargement, that is end aortic pressure, because aortic pressure is nothing but the last ventricular pressure. Same things. So Laplace law is this system where the heart is started to beat and relax and contract by the law of Laplace law. So it's not necessary, but you can go through the read the notes part 2 also. And in Starling law means the increase in the end diastolic volume will produce large stroke volume. It is very important things. And the occurs up to the point beyond the cardiac fibers, so it will be stressed and stroke volume will fall once more. The important regulation of cardiac output in the cardiac transplant patient who needs to increase their cardiac output. This is very important, a law that is usually maintained. Now the baroreceptor reflexes. Baroreceptor located in the aortic arch and the carotid sinuses. The aortic baroreceptor impulses travel via the vagus from the carotid via the glossopharyngeal nerve. The aortic baroreceptor impulses travel via the vagus from the carotid via the glossopharyngeal nerve. They are stimulated by arterial stretch. Okay. When artery is stressed, baroreceptor is stimulated, and in that case pressure is high. Our nervous system thinks that pressure is high. In that case, baroreceptor is stimulated and pressure becomes down. and even the normal pressure, they are tonically active. And what factor that increase baroreceptor stimulations, that is increase parasympathetic discharge to these SA nodes, decrease sympathetic discharge to ventricular muscle, causing decreased contractility and fall in the stroke volume. That is, when baroreceptor is stimulated, when the pressure is become fall down. In that case, like parasympathetic will relax the heart muscle. In that case, cardiac output will be low and the heart rate will be low. In that case, not significant amount of blood cannot pass through the brain. In that case, hypoxia occurs and increased carbon dioxide. In that case, baroreceptor is stimulated. Decreased sympathetic discharge through venous system causes increased compliance, and the decreased peripheral arterial vascular resistance. It is an emergency procedure. That is the first most important mechanism which is stimulated during hypoxia or acute blood loss. In case of surgery, you must know, during blood loss, the first mechanism which is activated to maintain the blood volume, that is baroreceptor, and then the sympathetic receptor. After that, sympathetic stimulation will be more. In that case, increased cardiac activity and increased heart rate. And the arterial stretch receptor located in the arterial junction between the pulmonary veins and vena cava, stimulated by the arterial stretch and are low pressure sensors. Increased blood volume will cause increased parasympathetic activity. Very rapid infusion of blood will result in increased heart rate mediated via the arterial receptor, the brain bridge reflex. Now, the decreases in receptor stimulation results in increased sympathetic activity. Okay, that will decrease the renal blood flow, because more stimulations and the more parasympathetic stimulation will raise the pressure. That's why if sympathetic system is activated, then more blood will go through the renal system and the GFR will be high. If the renal flow is decreased, then decreased GFR and the excretion and decreases sodium excretion, renal secretion of JG cell increase in the angiotensin 2. So it is a very common question in the MRCS part A. I already faced this question in January 2023 recently. This question came out. Okay, so increases arterial stretch will also result in increased release of ANP. Now the atrial activity. So this is very fundamental things, that is cardiac action potential. There are 4 phases. In the phase 0, rapid depolarization, rapid sodium influx, and this automatically deactivate after a few milliseconds. That is the first impulse which is generated by the SA node. Now the early repolarization, the efflux of potassium, and the play-2 phase, slow influx of calcium. Must remember these things, influx and efflux. You must not amalgamate or a mismatch. Okay, early repolarization means influx of potassium, and the slow influx of calcium is play-2. Now the final repolarization is efflux of potassium at peripheral. So efflux in 2 times, early repolarizations and the final repolarizations. In between 2 there is play-2, that is influx, sodium influx. It's like depolarization but slow, not acute but slow system. Now the restoration of ionic, the resting potential is restored, sodium potassium base, and there is slow entry of sodium into the cell decreasing, and the potential difference until the threshold is reached and triggering a new action potential. So here you can know that potassium, slow entry of sodium into the cell decreasing the potassium. So what cardiac stimulations or the cardiac action potential will be maintained or come to 0 by sodium influx. Okay, slow entry of sodium, that is restoration of ionic concentration. So cardiac muscle remains contracted 10 to 15 times longer than the skeletal muscle. Okay, must know. So conduction velocity. So atrial contraction spread on the ordinary atrial myocardial, no need. So this is no need. So what it the very most famous cartoons, that is here electrical impulse generated at the SA node. So SA node is stimulating the heart, that is atria. Then the impulse travels through the AV nodes where there is a brief delay, AV nodal delay, freeze. Okay, now the impulse is AV node, that is junctional complex through right and left atrioventricular nodes. Then it goes to the Purkinje fibers, then it gives stimulation to the ventricles and causes cardiac output. And there are 4 doors, that is 2 are tricuspid and 2 are the seminolar valves. Okay, so 1 mitral. So this lub dub means what? Okay, heart sound. So the ionotropes, that are cardiovascular receptors. So ionotropes and chronotropes, 2 important things, which is the factor or the receptor where the stimulation came out, and then heart is starting to increase beat or decreased beat out. So here you can see there are some ionotropes, that is adrenaline, alpha 1, alpha 2, beta 1, beta 2, and noradrenaline, alpha 1, alpha beta, beta. So these are the ionotropes. They will increase heart rate by increased force of contraction. Okay, and they also make the peripheral vasoconstriction by which pressure is increased. Dopamine, dobutamine, so they are beta 1, beta 2, especially dopamine, it will increase the blood pressure, and the dopamine also has a D1 and D2 receptor. So now the effect of receptor, one is usually constriction and the 2 is usually dilatation. Like you can see, the beta 1 increase cardiac constriction and heart rate by force of contraction, vasoconstriction. So alpha 1 also vasoconstriction, and beta 2 vasodilation. Okay, so alpha 1, alpha 2 constriction. So it is already noted by adrenaline and noradrenaline. They will increase alpha 1, alpha 2. So both are vasoconstrictor agent. But beta 2, that is dobutamine, or dobutamine causes beta vasodilation, and D1 and D2, that is dopamine, causes renal and splenic vasodilation, and D2 also inhibit release of noradrenaline. So dopamine and beta 2 receptor of noradrenaline, they will increase the flow of blood to the heart. That is, in case of septic shock, there is increased cardiac output, we all know. So cardiac output must be decreased because peripheral region there is a warm shock. So in case of septic shock, noradrenaline is usually prescribed. Okay, why? Because there is a beta 2 receptor which must be stimulated to decrease cardiac output, okay, by vasodilation. And dopamine also used for D2 inhibit release of noradrenaline. So dopamine must not use for septic shock, but it is used in the cardiogenic shock, where the cardiac output is must be kept low because the heart muscle is weak. In that case, cardiac output must be low or cardiac contractility must be decreased. In that case, dopamine or dobutamine is usually used. Okay. So this knowledge is very important for understanding the physiological consequences of heart muscle or cardiac output or heart rate or stroke volume with the shock, like distributic shock, like hypovolemic shock or septic shock. So there are 4 types of shock which is related with these receptors, where you will prescribe which drug. That is, septic shock is usually done for noradrenaline because we must make the peripheral vasoconstriction. Okay, that's why noradrenaline is used. Also, noradrenaline is used to make low the cardiac output. Okay, but in case of cardiogenic shock, we know the heart cannot beat up to the mark. That's why dopamine is used. Now the calcium homeostasis. So that is all about the cardiac physiology. Now the metabolic abnormality with the calcium homeostasis. Calcium ions are linked to wide range of physiological processes because largest store of bodily calcium is contained within the skeleton. Yes, we know that because calcium store is at the bones, the bone mineralizations, calcium sulfate, calcium phosphate, salt, which is stored in the bone. And the calcium levels are primarily controlled by the parathyroid hormones and the vitamin D and the calcitonin. And we will discuss with their activities and if what they actually did to our body to maintain calcium homeostasis. Here the parathyroid hormone, it increases the calcium level and decrease phosphate level. Each and every line is important. You must memorize each and every lines in this case. This is very important. And increase the bone resorptions, immediate action of osteoblasts to increase calcium in the extracellular fluid. Osteoblast, that is bone forming cells. Parathyroid is it used to bone form to increase calcium in intercellular fluid. And osteoblasts produce protein signal molecules that activate osteoclasts, which causes bone resorption. So parathyroid causes bone resorption because when there is a deficiency of calcium, in that case parathyroid hormone is increased. That's why calcium came from bones to the extracellular fluid, okay, by resorption. Increase the renal tubular reabsorption of calcium. It also helps in renal system to reabsorb calcium in the distal convoluted tubule, and it increases synthesis of 125 dihydroxycholecalciferol in the kidney, which is increases bowel absorption of calcium. So these things, that is part of the vitamin D, which helps to indirectly increase calcium absorption from the gut. So it is indirect action of parathyroid hormone. And the decrease is the renal phosphate reabsorption. So parathyroid hormone hates phosphate, so it also decreases reabsorption of phosphate. And 125, it helps or it likes both phosphate and calcium also. So increase the renal phosphate absorption and increase plasma calcium and plasma phosphate also. Increase the osteoclastic activity and increase the renal tubular reabsorptions and the gut resorb absorption of calcium also. It increases both, and the calcium hates both of them, that is both parathyroid and also D3. That's why it will inhibit everybody, that is inhibit calcium osteoclastic activity, inhibit renal tubular reabsorptions of calcium, inhibit intestinal absorption, and also secreted by the C cell, that is parafollicular cells of ultimopancreal body, that is fifth pouch, which is derived from the fifth pouch. So both growth hormone and the thyroxine also play important small role in the calcium. Both hormones and the thyroxine, that is thyroid hormone, also plays some roles in the calcium metabolism. Now the hypocalcemia. Here there is a mnemonic cat's go numb, convulsion, arrhythmia, tetany, spasm, and stridor. It means this is in short signs and symptoms of hypocalcemia. There are some conditions in the exam that comes from this diagram. Vitamin D deficiency, osteomalacia, acute pancreatitis causes hypocalcemia also, chronic renal failure, hypoparathyroidism, that is post thyroid and parathyroid surgery, pseudo hypoparathyroidism, target cell sensitive PTH, and the rhabdomyolysis if muscle is lost. There is an exam when they ask about the rhabdomyolysis, so that is a hypocalcemia in the January 2023. Here in the MRCS part A exam, the rhabdomyolysis is asked. Okay, so magnesium deficiency due to end PTH, that is when it occurs, that is chronic fasting or the starving condition, chronic starve or prolonged starving. There is magnesium and phosphate deficiency, in that case associated with hypocalcemia occurs. So management, that is calcium gluconate and the intravenous fluid. Intravenous calcium chloride 10 ml 10% fluid, and also ECG monitor calcium and carbonate should not be administered via the same route. Okay, we must remember. So severe hypercalcemia is with intravenous replacement, that is calcium chloride 10 ml 10% sodium with 10 minutes. Now the hypercalcemia, Shiphanges, okay, must remember, very important. Calcium supplementation, hyperparathyroidism, thiazide diuretics, milk alkali syndrome, Paget's disease of the bone, very important for hypercalcemia. Hyperparathyroidism, neoplasia, any neoplasia can cause hypercalcemia, like lung, like breast, like prostate, thyroid can cause hypercalcemia. Zollinger-Ellison syndrome in men 1, excessive vitamin D and A toxications, and sarcoidosis also. Must know the sarcoidosis. Okay, sarcoidosis is very common in UK. That's why sarcoidosis is asked in the exam. Sarcoidosis is somehow steroid dependent. If steroid you prescribe steroid, sarcoidosis may be remission, maybe goes to the remission phase, but it will be controlled. Malignancy, most common causes of hospital inpatient, and the primary hyperparathyroidism commonest cause of non-hospitalized patients. Okay, so but that is all. The stone, bones and abdominal groins. Okay, high serum calcium level results decrease in neuronal excitability. Okay, there will be sluggish reflexes, muscle weakness and constipation may occur. Now the management of the hypercalcemia. So how hypercalcemia may be managed? It is very important for part A, that is QT shortening. Okay, and the free calcium affect pH, increase acidosis. In case of acidosis, hypercalcemia occurs. And so if the calcium more than 3.5, consciousness is reduced and severe abdominal pain and prerenal failure. That case 0.9% normal saline in 24 hours. First things first. Then concurrent administration of calcium will help you lower the calcium level. Medical therapy corrected more than 3. So that is all. Intravenous fluid, that is normal saline 1 to 2 liters in 24 hours, and also you can administer calcitonin if it is available. I think it is not available always because it is somehow costly, but normal saline is available. So now the prevent osteoclast activity, attachment to bone matrix to interfere osteoclast activity, inhibit bone resorption. So IV zoledronate and pamindronate also come to the point. Okay, and the zoledronate. So pamindronate and zoledronate is newer drugs which is used for remission of hypercalcemia. So most potent agent is pamindronate. Malignancy associated hypercalcemia, they use zoledronate. So calcium quiesces onto the actions, however short duration, therefore only given in the second agent. So it is not the first agent because it is a short acting, not long. Prednisolone may be given in hypercalcemia related to sarcoidosis. I already told you that in case of sarcoidosis there is administration of steroid. So if in the question you see the you see the administration of the steroid will reduce the remission of the disease. So now which disease may cause hypercalcemia associated with it? In that case it is called the prednisone. Okay, so myeloma and vitamin D intoxicants also. Now the hyperkalemia. So hyperkalemia plasma potassium levels are regulated by the number of factors like aldosterone, acid base balance, insulin levels. Okay, now the hyperkalemia, that is increased potassium, which is including aldosterone, acid base balance and insulin level, because aldosterone is usually control the potassium levels in the renal system. Some people or me also thought that aldosterone is a mineralocorticoid, so it is mainly dependent with sodium, but no, that is not correct. So aldosterone causes potassium control. So aldosterone will maintain the potassium levels because potassium is exchanged with hydrogen. So the more acidosis, so more potassium into the blood. that is hyperkalemia. In that case, acidosis also make hyperkalemia worse. Okay, so metabolic acidosis is as hyperkalemia by hydrogen and potassium ion compete with each others, okay, and exchange with sodium ion across the cell membrane, distal tubule. Very important, very important, these two lines. Okay, okay, so you must remember these two lines. Metabolic acidosis is associated with hyperkalemia, and hydrogen and potassium ion compete. That means they will go to opposite to each other for exchange of sodium ion across the cell membrane and in the distal tubules. So ECG changes seen in the hyperkalemia: tall T tube, T wave, and small P wave, widening QRS. That is things. Okay, so ECG changes seen in the hyperkalemia: tall T wave, small P wave, and the widening QRS. And hyperkalemia, that is potassium sparing diuretic like spironolactone, if I say. Angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, spironolactone, cyclosporine, heparin. You must know the heparin. Okay. Oh no. Yes, heparin causes hyperkalemia. Remember, it is very important. We know that everybody will understand this or remember it, but they will forget heparin. Heparin is asked, okay, no matter what. The metabolic acidosis, Addison's disease, and the Addison's disease causes hyperkalemia. Okay, another one of the important things. Metabolic acidosis, Addison's disease, tissue necrosis or abnormalities, burn, trauma, and the massive blood transfusion causes. So each and every point is very important for exam. Now the beta blockers interfere with potassium transport into the cells, can potentially cause hyperkalemia, renal failure patients. Remember, beta agonists, salbutamol, are sometimes used in emergency treatment. So beta blockers will increase potassium goes into the cell. That's why beta blocker, that is salbutamol, is used act as a hyperkalemia treatment. Okay, so both unfractionated and low molecular heparin can also hyperkalemia. Okay, you must remember that. Inhibit aldosterone secretion, because aldosterone will increase potassium, so potassium excretion. But if you block the aldosterone, the potassium will remain within the blood vessels. In that case, hyperkalemia persists. That's why heparin causes hyperkalemia. It will inhibit aldosterone. Okay. And the some emergency treatment are sometimes used as emergency treatment. Okay. Foods are high, no need. Now the hyperkalemia. So hyperkalemia is hypokalemia. So potassium and hydrogen can thought competitors. Okay, they will exchange with each other, and the hyperkalemia tend to associate with acidosis, because as the potassium levels rise, fewer hydrogen ion can enter the cells. Okay, the hypokalemia and the alkalosis, that is vomiting, diuretics, Cushing's syndrome, and constant primary hyperaldosteronism. Hypokalemia, that is diarrhea, renal tubular acidosis, acidozolamide, partially treated diabetic ketoacidosis. So diarrhea, acidosis, acidozolamide, so they will secrete more potassium from the renal system. That is diarrhea, acidosis, or loss. How diarrhea losses? Because it will increase more potassium secretion by rectum, because we know that which organ is very important for secretion of potassium in our body, that is rectum. First one is a salivary gland, and the second one is rectum. So if you vomit more, then you will lose more potassium. If you caused more diarrhea, then in that case potassium level will be low. Okay, in case of renal tubular acidosis, that is all, because if acidosis occurs, aldosterone will not come to the metabolites or solutes. In that case, potassium will more secreted to the tubules and washed out. Acetazolamide causes loop diuretics. Acetazolamide, that is, it is one of the diuretics, causes more sodium potassium excretion. Partially diabetic ketoacidosis is called hypokalemia. So ECG hypokalemia, that is U wave, very unusual U wave, absent T wave or T wave inversion. If I say ST depression, prolonged QR, PR interval, long QT. So you have no pot, no T, but a long PR and a long QT. That is no P, no T, and U. Okay, PT no, flat, and U wave present, and the long PR and QT interval. Okay, hypokalemia. So very important, hypokalemia. You just see the ECG. That is PR interval is prolonged, ST depression, T wave and prominent U wave, extra wave, and the shallow T wave. Okay, another one is a PR interval, QRS wide and T tall. Okay, now hypomagnesemia. Hypomagnesemia is one of the important metabolites, metabolic syndrome, that is alcohol, hypokalemia, hypocalcemia associated with it, diuretics, TPN. Now in the Bailey labs, I saw that total parenteral nutrition. I have told in my Bailey lab lecture of the fluid nutrition, there is a diagram of total parenteral nutrition related disorders, because hypomagnesemia and hypophosphatemia are one of the two important metabolic problems that came to Cabiven treatment, or the total parenteral nutrition. In our country it is called Cabiven. We all know that Cabiven, what it is. And the paresthesia, tetany, seizures, and the arrhythmias also, and the decreased PTH secretion, hypocalcemia, that I already told you about that. Now exacerbates dioxin toxicity also. Now the hyponatremia. Okay, that what is it? Hyponatremia means the decreased sodium concentration to the blood. It is one of the important things, because in case of massive vomiting or massive use of loop diuretics, or also increase amount of loss due to burn, due to blood loss, hypocalcemia, hyponatremia is usually encountered. And overuse of 5% dextrose in the surgery. Okay, in case of exam, I already faced this question. Most common cause in surgery in the over administration of 5% dextrose, that is SIAD, syndrome of inappropriate ADH secretion, is caused by the increased DA administration post-operatively. We all know that DA is the best fluid in case of post-operative period, but overuse of DA causes hyponatremia. Hyponatremia may cause water excess and sodium depletion. Pseudo hyponatremia occurs in case of hyperlipidemia, like in case of prostate surgery or TURP operations. We will use glycine for irrigation. Okay, per-operative irrigation, also the post-operative irrigations. In that case, dilutional hyponatremia occurs. Okay, so if the urine sodium less than 20, more than 20 millimole, where that is antidiuretic hormones, increase sodium and urine, mnemonic, syndrome of inappropriate ADH secretion. So more sodium will be excreted. So SIAD, what is SIAD? That is serum osmolarity will be low, but urine osmolarity is high. Kind of opposite. Okay, it is because it's not common. As you know, in case of dehydration, what is already occurred, because osmolarity of the blood will be more and the urine osmolarity will be less. But in case of SIAD, that is opposite. Okay, you will give more DA and it will invite more chances of SIAD, or syndrome of inappropriate ADH secretion, where serum osmolarity is low, urine osmolarity is high. Now the urine sodium less than 20%, sodium depletion, extra loss, diarrhea, vomiting, and the sweating, burns, adenoma. I already told you that if there is a loss of fluid by the villus adenoma, okay, more potassium is increased, and water excess, that is secondary hyperaldosteronism, GFR, IV dextrose, and psychogenic polydipsia. So management acute hyponatremia with the sodium less than 120, immediate therapy, and central pontine melanosis may occur from overly rapid correction of the sodium serum sodium. They aim to correct until sodium is 120 and the rate is 1 milliequivalent per hour. Normal saline with furosemide is an alternative methods. Now the sodium requirement, this is by huge 0.6 in the body weight in the 125 milliequivalent. Hyperuricemia. So just remember what are the causes of hyperuricemia. That is cyclosporine, alcohol, nicotinic acids, and the thiazide, I hope so. Loop diuretics, aspirin, pyrazinamide. Okay, now the potassium secretion by GIT. So you must know the normal secretive value. Like rectum, you see the mostly, I already told you that where potassium is secreted more. First is salivary, and the most important organ where potassium is morely secreted, that is rectum. Another one is a salivary gland, variable up to 60. Okay, first one is salivary, then the third. Now the iron metabolism. So key point, remember the exam, the gastric potassium secretion are low, hypokalemia may occur in volume, vomiting, usually wasting, renal wasting potassium, not potassium less than vomiting. Now the iron metabolism. This is one of the important metabolic features after that. That is iron is absorbed in the duodenum and part jejunum, 10% dietary iron reabsorbed, ferrous much better absorbed than ferric. Okay, ferrous ion is oxidized to form ferric ion, which is combined with apoferritin from ferritin. Decreased by the vitamin C and gastric acid, decreased by proton pump inhibitors, tetracycline, gastric achlorohydrate, tannin, like tea. Tea, eating a lot of drinking a tea will increase iron. Okay, increased by vitamin C and gastric acid. Vitamin C will increase, helps in iron reabsorptions. Okay, gastric acid, vitamin C, which helps to increase iron reabsorption. And ferrous is much better absorbed than ferric, because we eat the iron containing food as a ferric ion, then it will absorb and convert it to the ferrous in the enterocyte. Then ferrous is again converted to ferric ion, which is combined with apoferritin. Then it combined with the transferrin and transport to the different organs like liver, like skeletal muscles. They will act as a storage. Here ferric is bound to the transferrin. Okay, now ferric, then ferrous, then it again converted to ferric and the bound to the transferrin. And ferritin or hemosiderin in the bone marrow, it will storage, that is iron is stored in the bone marrow, and the excessive loss of intestinal tract desquamation. Okay, and where is the most important source of iron of our body? This is hemoglobin, 70%. Then hemosiderin. Now the pulmonary artery occlusion pressure. So PAOP, pulmonary occlusion pressure is the indirect measure of left atrial pressure. Okay, pulmonary arterial pressure is called the left atrial pressure, must know. So low resistance with the pulmonary venous system allows useful measurement of the MEG. The most accurate trace is inflated by balloon or inflation of the balloon by which PAOP is measured. Systemic vascular resistance about 80 derived from aortic pressure and the right atrial pressure and cardiac output. When combined with the measurements of systemic vascular resistance and cardiac output, it is possible to accurate classify patient. Now respiratory physiology, the lung compliance. Lung compliance is defined as change in the lung volume per unit change in the airway pressure. Causes increase in compliance, age, emphysema is called increased pressure, and the decreased compliance is fibrosis, pneumonectomy if pulmonary edema. There is obstruction and collapse of the lung can decrease compliance, and the emphysema causes there is increased space to the lung. That's why the elasticity is more during age or emphysematous patient. Now the transfer factors and the control of ventilation. Now the respiratory system, we already entered to the respiratory system. Now the transfer factors. So the transfer factor describes the rate which gas will diffuse from alveoli to the blood, and the carbon monoxide is used to test the diffusion. So Ray's transfer factor, asthma, Wagner's granulomatosis, and Guth-Pasteur syndrome, left to right cardiac shunt, polycythemia, hyperkinetic states, pale gender, low pulmonary fibrous pneumonia. There is obstructive related problems. Not necessary. Control of ventilation. So through things, that is apneustic centers that will stimulate the inspiration, prolonged inhalations, and the pneumotaxis center upper points inhibit the respiration starting points. And the control of ventilation is correlated with respiratory centers, chemoreceptors, and lung receptor and muscles. Automatic involuntary control respiration occurs from medulla. It is important for exam. Now the ventricular variables, the levels of PCO2 most important in ventilation control, and the levels of oxygen are less important. Peripheral chemoreceptors located in the bifurcation cavity arteries and arch of aorta. Okay. They respond to change in the reduced oxygen and increase hydrogen and increase partial in the arterial blood. So what is the function of chemoreceptor? Because they are chemically active, so they are usually so much connected with oxygen and carbon dioxide. If there is a decreased oxygen pressure or oxygen level, then chemoreceptor is stimulated because they are usually so much sensitive with partial pressure of carbon dioxide and hydrogen level. If they increased, then chemoreceptor is activated and increase respiratory rate to make hyperventilate. So more carbon dioxide or hydrogen will be excreted out through hyperventilation, then oxygen is restored. So central chemoreceptor located in the medulla, and the response of increased hydrogen in brain fluid, that is CSF, increased ventilation, and the central receptor not influenced by oxygen. So oxygen is not so much sensitive with central chemoreceptor. Okay, that is partial pressure of carbon dioxide, and the hydrogen is more sensitive for the chemoreceptors. Now the alveolar ventilation. Alveolar ventilation is volume of fresh, that is minute ventilation minus dead space. The actual ventilation occurs in the alveolar ventilation, and the minute ventilation tidal volume in the respiratory rate. Okay. Now anatomical dead space is 150, and the volume of gas respiratory not involved in the gaseous excess, mouth, pharynx, trachea, and bronchi up to the terminal bronchioles. And measured in the Fuller's methods, and increase in the size of person increase lung volume and drugs causing bronchodilation like adrenaline. So standing and increased size of the person, like big body surface area, the increased lung volume and drug causing bronchodilation of adrenaline. And the physiological dead space is normal 150, and volume of gas in the alveoli anatomical dead space not involved in the gaseous exchange. Okay, like pulmonary embolism, COPD, and hypotension, COPD, this is physiological dead space because lung is damaged, so the area of ventilation will be less. In that case, that is all about the physiological dead space. In case of, because physiological dead space is pathological sometimes, like PE, pulmonary embolism, or COPD or hypotension, so there is a pressure related problem and also the disease of alveoli, so the surface area is reduced and the physiological dead space is also increased. A lot of things is also came out. So okay, so that is all about today's lectures, because I must not increase the length of the lecture because physiology is very important. You must think, you must understand the portion of physiology within some time period. If I elongated the lecture, if I increase the lecture amount, it will be clumsy, or sometimes you cannot capture a lot of information within a short time. So In the next video, I will discuss about the respiratory system along with the endocrine system as well. So thank you very much for watching my videos, and I hope you will you already saw my previous videos, but and thanks for subscription. And I will again say, please like and subscribe my channel, and also see the future videos about the surgery basics along with the systemic surgery. In near future, I'm going to start the garden or principal practice of surgery along with the Bailey labs, and I will always also discuss about the short summary diagrams, questions, and the evaluation of the pictures of Bailey lab 28 editions, also 27 editions, and also they discuss about the question of MRCS part A later on along with these lectures. After the finishing of these basics, we will going to practice about MRCS question regarding the basic and as well as the principal practice of surgery, that is POSG exam. Thank you very much for and keep subscribing and like my channel, and also invite the students of international as well as different communities. Thank you very much. Peace. Don't forget to subscribe and like my channel. Okay, thank you.